seeing spinal cord injury has been elusive to all of us, and we believe that seeing helps understanding. I would like to invite Dr. Shekar Kurpad, Chairman and Professor at the Department of Neurological Surgery and Director of the Spinal Cord Injury Center at Madison, Wisconsin, to give us a presentation of how advancements in visualizing spinal cord injury through advancements in technology can help us understand and predict the injury, and also see how treatments can help patients. Dr. Kurpad?
It's always a difficult proposition to follow Dr. Fehlings because of the quality of his presentation, but I will do my best. So my charge today is to talk about imaging advances in spinal cord injury. I want to first begin by acknowledging our funding sources that enable us to do some of the research that we do in terms of working on some of these imaging advances, primarily based on MRI technology. So as part of the AO Spine guidelines working group, about 2 years ago, we really framed the state-of-the-art of MRI scanning in spinal cord injury. Certainly, plain X-rays and CT scans have preceded MRI scans for a number of years. But really, in terms of seeing spinal cord injury, as Dr. Chapman just mentioned, MRI is really the only soft tissue modality which allows us to see the actual extent of spinal cord injury. So some of the questions that were framed include the following. So does baseline MRI influence management strategy? Does it affect neurological, functional, or patient-reported and safety outcomes? Do MRI observed intramedullary spinal cord lesion characteristics, pattern, and length identified on baseline MRI predict neurological, functional, or patient-reported safety outcomes? Do spinal cord characteristics identified on diffusion MRI predict neurologic function, patient-reported, and safety outcomes? And is baseline MRI cost-effective? These are the questions posed by the guidelines working group of AO Spine a couple of years ago. So in direct answer to some of those questions, the group met on multiple occasions, reviewed all the available literature, of which there was quite a number of papers, almost 800 manuscripts, and found that direct evidence supporting the use of baseline MRI in spinal cord injury is actually minimal. There was considerable variation in the use of baseline MRI worldwide. MRI characteristics, specifically the length of intramedullary hemorrhage, canal diameter, are moderately sensitive as prognostic signs. There was no substantive literature investigating DTI as a predictive tool in spinal cord injury, which I'm going to talk about a little bit at length later. There's no literature that examines the cost effectiveness of MRI, and the lack of literature in all these areas highlighted the need for well-designed studies, as I will end with in my talk, using standardized methodology to fully characterize the utility and cost effectiveness of MRI in spinal cord injury. So what do we have now in terms of conventional MRI-based spinal cord injury biomarkers? We know that in cervical spinal cord injury, cord swelling and intramedullary hemorrhage might predict Asia motor score, as shown by Myangi et al., and then that maximum spinal cord compression, cord hemorrhage, and cord swelling are likely associated with poor neurological prognosis. In another study done by Bizan Arabi's group with 68 cervical spinal cord injury patients, a higher rate of lesion expansion was noted to occur in Asia A and B patients versus Asia C and D patients. One of the problems is that following spinal cord injury, conventional MRI techniques, i.e. T1, T2 weighted techniques, are sensitive to edema, hemorrhage, and injury morphology, but are not predictive of long-term dysfunction. This is essentially a grayscale image. One solution would be to try and use and measure diffusion in the substance of the spinal cord and use diffusion-weighted MRI, which has been our approach among other groups, in many other centers that study spinal cord injury. Why DTI? So traditional MRI is not sensitive to axonal injury. Diffusion imaging is likely, at least by hypothesis, thought to be more sensitive to axonal injury. Diffusion imaging could therefore yield prognostic and treatment-relevant information, and the goals were to determine if DTI was sensitive to the structure of the spinal cord in the context of injury, was sensitive to remote changes in the spinal cord, remote from the area of injury, and thus study various DTI indices as potential biomarkers of spinal cord injury, spinal cord structure and function after injury. Our own approach has been to use a reverse translational approach, which I'll describe in a little bit. DTI technology is essentially based on basic physics. It's based on the measurement of diffusion of water molecules in a slice of tissue in various directions. So if you have no constraints on the left, water molecules would have a spherical diffusion profile. But if you have membranal constraints like an axon, you would have an ellipsoid diffusion profile, yielding DTI indices in the range of 0 to 1, as shown over here. To the right would be a completely anisotropic profile, as one would expect to see in a bundle of healthy axons, and to the left, a completely spherical isotropic profile, such as would be seen in a completely disrupted area of tissue with unhealthy axons. DTI yields various indices. FA is the most common index used, called fractional anisotropy, more abnormal or reduced when there's less myelination, less axons, or more extracellular volume, and more normal when there's more myelination, more axons, and lesser extracellular volume. ADC, or apparent diffusion coefficient, measures is more abnormal or reduced when myelin is less thick, axons are thinner, axon diameter is less, and there's more neurofilament and microtubule density, and the opposite would apply with LADC being more normal. Mean diffusion simply measures the overall extent of diffusion of water molecules in a slice of spinal cord tissue, and it's a direct function of tissue water. Less tissue water means reduced mean diffusion, and more tissue water means increased mean diffusion. So with that as background and definitions, we adopted a couple of different approaches to apply diffusion imaging in the context of spinal cord injury, and we've also done some work with cervical myelopathy. I will describe two of our approaches. One is remote DTI, and show some of our data and compare with other groups that have worked on the same subject with animal data as well as patients with spinal cord injury, and then specific problems of imaging near spinal hardware and double diffusion encoding, which is a newer technology to look at the lesion site using DTI. So these are the two approaches we have taken. I will talk about the one on the right side first, which is the remote cord imaging, and then follow with some comments about acute cord injury assessment. So the rationale for remote imaging is predicated on a model well described by Dr. Fehlings and Tatter in Toronto of secondary injury and spinal cord injury. So in other words, as shown on the right, when there's injury at a certain area of the spinal cord, remote DTI, further cephalad, we hypothesized would show diffusion changes indicative and predictive of the extent of injury. In an animal model, we and others have been able to show that diffusion changes are evident in the cervical spinal cord, as shown in the top panel, much rostral to the level of lesion following a severe thoracic contusion injury, as well as caudal. In addition, cervical diffusion imaging appeared to predict injury severity after inducing experimental thoracic spinal cord injury in an animal model, as shown in the lower left panel, and that the degree of severity of injury was correlated with correlation with BBB scoring for hind limb strength. In addition, not only was there correlation with the degree of injury severity, but there was also correlation with the amplitude of evoked spinal somatosensory evoked potentials in the dorsal columns, the medial and lateral spinal thalamic tract, as shown in this figure. In fact, diffusion was found to be altered as far proximal from the zone of spinal cord injury as the brainstem and the cerebral hemispheres, indicating that there is a fairly significant homeostatic process in terms of diffusion, at least, that changes in the entire neuraxis after a relatively focal area of injury. So to summarize the animal data really quickly, we and others have been able to show that proximal diffusion imaging is a biomarker potentially for more distal spinal cord injury. It might correlate with known measures of spinal somatosensory function, correlates with spinal cord injury severity, and there was some evidence that diffusion imaging proximally may be a biomarker for structural changes after stem cell transplantation. So with this in background, and others translational field studies involving patients with vascular injury as well as cervical myelopathy. So, applying the diffusion tensor imaging model in a cohort of chronic spinal cord injury patients, we studied a group of 10 cervical and thoracic chronic spinal cord injury patients and compared to 13 controls and showed that there was a marked reduction in anisotropy at the level of injury. In addition, when you look proximally, there was a significant reduction in ADC or apparent diffusion coefficients and mean diffusivity, which is shown here in a group of chronic spinal cord injury patient cohort compared to controls, with a significant p-value difference between the groups. Other groups showed similar results. Diffusion imaging showed reduced anisotropy rostral to the injury site in chronic spinal cord injury, Peterson and Patrick Freund in Switzerland. Fractional anisotropy in the high cervical cord in patients appeared to correlate with tibial SSEPs, and fractional anisotropy of the corticospinal tract in the high cervical cord correlated with upper limb function. So there was motor and sensory correlations in a chronic spinal cord injury cohort. These changes appeared to also occur in acute spinal cord injury. Here's an example of a study where 11 patients with cervical cord injury were compared to 11 controls and underwent early DTI. And we measured two things. DTI metrics were measured at two levels, one at the high cervical cord and one at the injury zone. So in other words, here's a schematic of the spinal cord injury and where we measured diffusion changes in the spinal cord in the acute setting after spinal cord injury. So as seen in this figure, there was a significant reduction in fractional anisotropy in spinal cord injury patients versus controls, and this was detectable in each of the funiculi of the white matter in the spinal cord. And there was an opposite mirror change in mean diffusivity, which would be expected because spinal cord injury patients would have more random diffusion of water molecules compared to controls. So that's sort of the background with remote cord imaging. So now I'd like to move on to acute cord injury assessment. So we've previously done studies that has been replicated by others looking at in vivo lesion site imaging using diffusion imaging in an animal model. So essentially showing that there was a significant increase in mean diffusivity at the region of injury that correlated histologically to cavitation of the spinal cord from 0 to 25 weeks after spinal cord injury. There's been 3 manuscripts that have been published in spinal cord injury patients looking at lesion site diffusion tensor imaging, and essentially indicate that DTI data at the injury site in non-hemorrhagic contusion might correlate with Asia exam and spinal cord injury severity. And this is a paper published by Bizan Arabi's group back in 2011. But again, the study was limited by small patient numbers, and there was no clinical follow-up to assess long-term prognosis. One of the new techniques that we and some other groups have come up with is called double diffusion encoding. As a background to that, diffusion imaging detects microstructure changes from injury. And since, as I mentioned before, diffusion occurs in all directions, it can be hypothesized that each direction of diffusion holds unique information. So that's important because if you correlate that to my Fehlings is one of my Fehlings is many papers on the subject. Axonal integrity is the most direct functional status predictor. So in other words, diffusion along the craniocaudal axis, which might be an indicator of axonal integrity, might be something that might be of interest in using diffusion imaging as a prognostic marker. So here's a schematic of that concept, trying to filter axial diffusivity from radial diffusivity, and then only looking at axial diffusivity as a measure of axonal integrity. So in other words, what we can do is we can apply a perpendicular filter and only detect parallel diffusion and thus probe axonal injury, and that allows us to measure axonal injury without contamination from edema or CSF. So here's a schematic to show just that. So here's an example of no diffusion weighting. So in this top panel, you're measuring diffusion in all directions. When you apply the diffusion filter or probe, we can only see the restricted fraction of axons diffusing and we're able to compute water diffusion only in a craniocaudal direction. As it turns out, this is possible to do even in a small animal model, and we're now applying it in patients. And you can actually do it with reduced acquisition time. There's no need to calibrate regions of interest. There's immediate quantification. There's no need for post-processing, as it turns out, and it certainly eliminates variance between scanners because the filter cancels out the variance that you can see between scanners. This is an example of DDE, or double diffusion encoding, in a rat contusion model. And this actually compares at early, just 2 days post-injury, there's a significant improvement in DDE versus DTI in rat spinal cord injury. In other words, for various severities of injury, for varying severities of injury, DDE appears to detect very early after injury the varying degrees of spinal cord injury, as opposed to DTI, which doesn't yet detect the changes in diffusivity in proportion to the severity of injury. In addition, there's a clear linear correlation of DDE with the degree of compression based on injury biomechanics, and there's also a better correlation as early as 24 hours with BBB scoring with the various severities of injury. So what are the limitations? It all sounds very good, but obviously any new technique has a number of limitations. The problem is DTI measures Gaussian diffusion in the regions of interest, and thus does not necessarily reflect one pathologic processes. There may be many pathological processes since you're measuring a non-specific entity like diffusion, so probably a combinatorial method might be a better way of predicting exactly what's going on histologically in the spinal cord. This was nicely summarized in a paper by Kadat and in Mike Fehlings group very recently. So in conclusion, we can at least say that diffusion imaging appears to detect changes in the cord not visualized on T2-weighted images, and it can detect changes both at the level of maximum compression as well as rostral. Basically, hardware and signal-to-noise ratio issues can be effectively addressed by newer diffusion-based sequences. I've shared with you one example, and that diffusion changes significantly correlate with upper extremity motor function as well as sensory function, and therefore, for all these reasons, might be a prognostic and treatment biomarker for spinal cord injury patients and also cervical myelopathy patients. At least in our institution, and now I know in some other institutions, including Toronto as well as in Philadelphia, it is a sequence that is added to all cervical preoperative MRI scans in spinal cord injury patients. So obviously, where do we go from here? We need to determine the current state in MRI usage. There's a lot of variability, as I mentioned in my first slide. Combinatorial metrics should be developed further and studied in a larger number of subjects. Reverse translational approaches are important. They offer excellent windows into refining newer techniques. Multi-center data input is critical. Image acquisition standardization is critical. ROI, or region of interest selection and processing standardization, is also critical. This is being worked on with Dr. Kwon Adode's toolbox that is being developed at Montreal and Toronto by Alan Martin in Michael Fehlings' group. And then the next step is really, what is the role of diffusion imaging in clinical and preclinical trials for various therapies, such as the ones that Mike Fehlings just mentioned. And obviously, to do this type of work, we all need a lot of funding, so that's obviously an ongoing challenge. So with that, I think I'll stop. Here are my acknowledgements, my graduate students and our group, and thank you very much.
Great job, Dr. Kurpad. Thank you for sharing this great talk with us. I think Professor Schildhauer has a question to you.
Yeah, thank you, Shekar. This was wonderful, and I'm glad that you're presenting these nice results. We often face in reality problems in the DTI technology because of hardware, because of tattoos, etc. These are reasons why patients cannot undergo 3 Tesla examinations. The companies are often setting the rules which patients can be included in the studies and so on. So I'm glad that you're also speaking about DDE, but how many patients in your hands actually can undergo these examinations?
That's an excellent question. So in our institution, every patient that comes in with a diagnosis of spinal cord injury in the acute setting has a DTI scan sequence added on. So we've worked very hard to minimize the length of time it takes, because these patients obviously have medical issues and they have hemodynamic issues and so on in the early stage after injury. So we worked hard, and we started at about 30 minutes or so for the sequence in the cervical spinal cord. Now we're down to about 8 minutes that we can get the sequence done. It's done on a 1.5 as well as a 3 Tesla scanner, so it's a commercially available scanner, so it's not any kind of special scanner. Obviously, you make an excellent point regarding the manufacturers of MRI scans. We are a GE facility. GE's medical headquarters is in our backyard, so we have all. Can you hear me now? But we've worked with other institutions which have Siemens facilities, for example. There is a difference. It turns out MRI scans, like people, have their own personality. So the data that you get is a little bit different depending on which scanner you get your information from. So we've worked actually with a number of other institutions which have Siemens scanners to see if we can standardize how we acquire images and how we interpret the data that we get from those images. And so there is a slight variance, but the general trend is very much the same. So, yes, the manufacturer does influence the type of data you get, but in general, the numbers that you get are similarly interpretable.
Very interesting perspective. So not only do you have different centers and different specialties, but also different companies to contend with. Brian, if you look into the near future, how can DTI and DDE affect your treatment of an acute spinal cord injury patient or a chronic spinal cord injury patient?
Well, that was a very nice presentation, Shekar. And I think that there's sort of two issues. One is that, I think in the acute setting, I think that the DTI will hopefully give us an ability to characterize the injury severity and give us some prediction of outcome. And I think that would be a real step forward if we could have something like that, and I'll speak to that as well. In the chronic setting, I think one of the real interesting values in that is once a lot of the acute pathophysiological secondary injury processes settle down, then it seems like it has a lot of potential to characterize really some of the, in more finer detail, and Shekar spoke to this, the actual the pathology of the injury itself. And this is where I think it would be very helpful to have that as a baseline for individuals that are going to then participate in a neurorestorative treatment at a later date. So I think that it, for in the acute setting, if it can help us tell something about what might eventually happen, and in the chronic setting to really provide a nice or an advanced picture of what the pathology of the spinal cord looks like at the time of the intervention. I think that those would be really valuable tools for us.
Jim, question to you. So Shekar showed visionary new imaging for spinal cord injury patients. Reality, frequently in our West Coast area, is we can't even get basic imaging protocols, such as MRIs, after spinal cord injuries established in at least our region of the world. Where do you see the implementation of protocols for imaging for spinal cord injuries in its implementation in the US?
Great question, Jens. It's interesting. I've been very fortunate, at least at our location, we have been readily available to get MRIs. So as I was listening to Shekar's presentation, I actually step back and I go back to Michael's presentation. And one of the problems with spinal cord injuries now is we have 0 therapies. So if you have 0 therapies, you do whatever we got, early surgery, steroids, Riluzole. And I think what he's showing us is all spinal cord injuries aren't the same. And so I think really what is going to come into play is 2 reasons. One is I think it's going to help with prognosis for a patient. But the second issue is I think we're going to be able to break spinal cord injuries down. And we're going to see the world doesn't equate to you're an Asian A or you're an Asian B. We know the conversion rates over the last 20 years are drastically different. It was 3%, and now in some of the studies, it's up to 70% of Asia A's convert. Why is that? And I think some of we're making these advances, we don't know why. As we start to understand the spinal cord, I think we're going to be able to target therapies like our brothers have done in oncology, chemotherapy, medicine, microbiology.
I think my partner, Dr. Oskouian, had a question about.
Yeah, I had Shekar. That was great. I just have a question as far as where do you see what's next in your research? What studies are you guys looking at as far as what are the sort of what do you see as the next steps of what you're doing?
So thank you for your comments. And that's an excellent question. I think we always want to see as clinicians and surgeons how are we going to apply this? Because it's nice to get diffusion data. It's nice to look at pictures of the cord, but how do we apply this in a clinical surgical setting to make a difference in terms of how we share prognosis with a patient, how we share how we're going to intervene with a patient, how we share what type of treatment, like Jim just pointed out, that was an excellent point as well, in terms of, this is showing us that spinal cord injury are heterogeneous issues, not just a homogeneous one-level based issue. But the next steps are so our constant quest has been to try to simplify the imaging so that we spend as little time to get as much useful information to make the next treatment decision. So our next immediate step is to take diffusion, double diffusion encoding and try and apply that in a clinical cohort to see if we can get some superior results in terms of prognosis compared to the regular diffusion imaging that we used to get. So that's our next immediate step. But then in a larger context, what we really need to do is correlate that back with histology to figure out like what it is that we're actually seeing with double diffusion encoding. So we're taking a reverse translational approach and we're going back to old-fashioned histology because really you need quantification by proven methods in order to prove that this new technology actually works in a way that's predictable.
So this was a very important session. I want to thank participants and Dr. Kurpad for his great new insights into imaging spinal cord injuries. If I may summarize, I think we're on a new horizon of offering a new classification and understanding of spinal cord injuries, and possibly, as Dr. Harrop had pointed out, targeted therapies for spinal cord injuries that we've not had before. And as Dr. Kwon pointed out, greater physiologic insight in terms of acute and chronic spinal cord injuries and implementation of new imaging protocols that we can all follow across centers, across manufacturers, and across border lines. Thank you, Dr. Kurpad. Thank you, our Collegium of Authors. Thank you.